I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of April 17th, 2024 at 9:34 a.m. To begin. So Melissa, if you could please call roll.
Chair Shelley Bailey.
Here.
Vice Chair Amy Burns.
Here.
Dan Hartung.
Here.
Robert Judge.
Here.
Chris Lehman.
Here.
John Murray.
Here.
Akil Patterson.
Here.
We have a quorum.
Perfect. Thank you, Melissa. So before we proceed, Mr. Murray, I would like to give you the floor to make an announcement. Hey, Mr. Murray, we actually can't hear you. You may be on mute.
My apologies. Chair Patterson, thank you. Under advisement of the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs. It's comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Thank you.
Mr. Murray, thank you for sharing that information. So the board will now adjourn to executive session pursuant of ORS 192.660 to consider information or records that are exempt by law from public inspection. Representatives of the news media or designated staff shall be allowed to attend the executive session. All other members of the public may not attend. The public may stay here in Zoom room. The board will return to open session in approximately 20 minutes. No decisions will be made in the executive session. And after executive session, the board will return to open session and welcome public back. Representatives of the media wishing to attend should call Melissa Stiles at 971-374-3734. Members of the news media are directed not to report on or otherwise disclose anything said during the executive session. So Melissa, if you could please transition us to executive session. All right, well, good afternoon. The board has returned to open session. No decisions were made during executive session. We will now call the roll to confirm a quorum. So Melissa, if you could please call the roll.
Chair Shelley Bailey.
Here.
Vice Chair Amy Burns.
Here.
Dan Hartung.
Here.
Robert Judge.
Present. I'm here.
Thank you. Chris Lehman.
Here.
John Murray.
Here.
Akil Patterson.
Present.
We have a quorum.
Perfect. Thank you, Melissa. And I also did want to ask members if anyone has suggested changes to the draft minutes from our February 21st, 2024 meeting. All right, well, if there's no suggested modifications, I would like to ask for a motion to approve the minutes from our February 21st meeting.
This is Amy Burns. I'll make a motion.
Thank you, Vice Chair Burns.
This is Robert Judge. I second.
Perfect, thank you. Melissa, if you could call roll related to the minutes.
Dan Hartung.
Can I abstain? I was missing. I was absent for about half the meeting.
Robert Judge.
Aye.
Chris Lehman.
Aye.
John Murray. John Murray.
I'm sorry. Yes. Aye.
Thank you. Akil Patterson.
Aye.
Vice Chair Amy Burns.
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Perfect, thank you, Melissa. So I'd now like to call on Executive Director Ralph Magrish to provide us with a program update.
Thank you, Chair Bailey, and I will move through this fairly quickly in the interest of trying to make up a few minutes on the agenda that is robust today. So as the March meeting was postponed, I can share that we held a Rules Advisory Committee on March 7th to implement provisions of Senate Bill 192, which created a shared fee structure to fund both the Drug Affordability Board and the Drug Price Transparency Program housed at DCBS. I can share that we've advanced 2 applicants to fill vacancies for board positions to the governor's office. So I should be in a place next month to share information on the status of those nominations. Next, I did present at the March 26th Cost Growth Advisory Committee meeting hosted by the Oregon Health Authority on upper payment limits with Jane Horvath of Horvath Health Policy, who is under contract with our agency to provide consultation and technical assistance. Next, we have held 3 community forums this month, one in Portland, one in Lincoln City, and one in Woodburn just this past Monday night. And thank you to all of those who participated in that. We have 2 more upcoming this month, one in Medford and one in Bend, and then 2 online in May. Both will have Spanish and ASL interpretation services available. And you will hear more about those forums as part of our Senate Bill 192 upper payment limit planning work later in the meeting. So thank you very much, Chair Bailey.
Perfect. Thank you, Ralph. So I'd now like to call on Ralph and Courtney Whitlock to start the discussion related to our new timeline and template for our affordability reviews.
And thank you again, Chair Bailey. I will start this section and hand off to Courtney shortly. So members of the board and the general public, as I've said in the past, we will continue and said this again in the future, that these affordability reviews are really a process of continuous learning and continuous process improvement. To that point, we are making some changes in those processes. First, we are working to make our public agendas that are more detailed, more user-friendly for those in the general public. In those agendas, we will try to be more specific about topics, speakers, content, and review of items being discussed. Secondly, we are modifying our stakeholder or constituent engagement process by creating additional time with the new calendar, and to review the cadence of those meetings and affordability reviews themselves to expand stakeholder processes and invitation to participate in this. It includes dividing comments and testimony time for individual drug reviews into more specifically defined opportunities for patients and caregivers, for the general public, for manufacturers, and for providers and carriers as well. Thirdly, we will be reviewing and revising the actual voting process for affordability reviews themselves. The board will amend processes to first hear comments and then move into discussion without conducting any final vote for selection until all drugs are reviewed. We will also allow information to be submitted on any given drug up until the final voting occurs in November, and that is the calendar that Courtney will go over with you shortly. So why is this important, everyone? It's important to help inform these analytic exercises consistent with our statutory requirements to identify drugs that may create affordability challenges for the healthcare system or high out-of-pocket cost for people in the state of Oregon. Let me further level set with people that the word may means to express possibility. That is the word that is codified in Oregon Revised Statute, and that's what it means. It means to express possibility. I'll also speak to the fact that we've heard concerns expressed about our data, the quality of it itself, the limitations related to its timeliness, as much of it comes from calendar year 2022. Much of that feedback has been specifically around net cost of drugs after rebates. So again, manufacturers, we welcome and invite you to share with us calendar year 2022 rebate, because as you've noted, we are now in calendar year 2024. And fourthly and finally, excuse me, we've pivoted and structured and redesigned the affordability review template itself. The goal there is to better illuminate requirements identified in statute and rule and identify the gaps in data where it exists. We have nothing to hide, nor have we ever tried to obfuscate the limitations of our data or those resources. With all of that said, I'd like to hand off to Courtney to walk through the revised calendar and the review the template. So take it away, Courtney.
Yeah, thanks, Ralph. Melissa, can you please transition to the timeline slide? Thank you. So we have had to reset the timeline for the affordability review and of the subset list of the 12 drugs that the board selected under the OAR 925-200-0010. And back in November and December, the board discussed and selected the subset of drugs from the list of the top 25 most frequently prescribed, the most costly drugs, and the greatest increase in total plan spend. From the list of the drugs, the board decided for this first review to process drugs and remove drugs that were identified on the Inflation Reduction Act list, remove drugs that had therapeutic equivalents and biosimilars, and that had an orphan designation or had both an orphan and non-orphan designation. Also, a discussion that was had was to remove the Creon group, albuterol, Symbicorp, and the Suboxone groups due to having multiple source drugs, multiple manufacturers, or generic and therapeutic equivalents. So during the reassessment of the drugs, it was identified that at least one of the drugs was considered a biosimilar, that is the Inflectra. And due to that being a biosimilar, to follow suit of the decision originally made back in November and December to remove it from the subset list going forward. Additionally, information was provided that Skyrizi has an FDA orphan drug designation for pediatric Crohn's disease, meaning Skyrizi has both a orphan and a non-orphan designation. So again, following the original decision to remove drugs with the both indication to remove from the list subset list. I would like to kind of transition back to the board to have a discussion if it is in your interest to remove those drugs, so that the timeline for starting with the review would be remove those two drugs so we can properly apply the material going forward. Yes, Dr. Burns, I see your hand up.
I had a quick question for you, Courtney. Is it possible to, when you're looking at the data, to pull the pediatric population out? So like, I mean, because for Skyrizi, since the designation is specifically for a pediatric use, if we were only looking at adults, we could say with good faith that we were not looking at the orphan designation indication.
So right now, my understanding is that we're only looking at an NDC drug that primarily is associated with adult treatment. But again, not having our data researcher or analysts to kind of fall back on for that information to be able to pull out specifically. My understanding is also that the Skyrizi orphan or the orphan designation for the pediatric Crohn's disease is associated with the large generic molecule of the drug. So, and that was not known at the time that the review was done. That's why that wasn't originally identified. So can we do it? That depends on how the going forward with that data review would look like.
And Courtney, if I may, Dr. Burns, I think with the all payer, all claims database being our prime source with this, that because there is no requirement for a diagnosis to be written on a prescription, it would be hard to do a one-to-one analysis to extrapolate individual claims tied to a pediatric diagnosis. Go ahead.
We don't, so I'm sorry, I'm familiar with the all players, all claim, but I don't know like the level of detail that you're getting. So you don't have, say, patient age.
I think we could look at a pretty extensive analysis there. We can certainly talk with the folks in our data team and that manage the all payer, all claims database at OHA and see if that's possible and get back to you on that.
I mean, that's just a thought if we did want to keep it in. I mean, to me, that seems like in pretty pretty obvious line that we could draw and say anybody who's falls under this age, we wouldn't look at that in case they were using the medication off-label for the indication that now has the designation. But that's just a thought.
No, we certainly can explore that. And Dr. Hartung, were you gonna?
Yeah, I guess my comment was that it doesn't, as of now, have an indication for the orphan drug designation. So I feel like we can proceed with it on the potential eligibles list, is my opinion. And in terms of trying to parse it out, you know, all of these drugs could potentially be used for any number of off-label things, including, you know, other rare conditions that they have various designations. So I think for that reason, I see it's like a very complicated type of analysis to try to parse those things out across all of these drugs, which, you know, you may have some use in for some orphan drug designations.
Well, and I guess to clarify, Dr. Hartung, I believe it has the orphan designation for pediatric Crohn's back to 2016, but it doesn't have the approval, right? So, I mean,
Right.
I'm in alignment with the sentiments that you shared, which is that it does not have orphan approval for the condition yet.
Right.
Well, so it has approval for the designation. The indication just hasn't been approved. So, I mean, that's where we're at with that. If that seems to align with what, you know, the rules allow us to do, then I don't have any issue with it. It was just a suggestion to try and parse out what we do know has the designation, even if that's not an approved indication. And I agree, like things are used off-label all the time, but I would imagine this is probably already being used off-label in pediatrics for that particular indication.
So then is it the intent of the board to keep it on the subset list to review in August, and maybe between this time and that time, we are able to provide a little more information if there are any known pediatric treatments?
I mean, I guess it would be my perspective that maybe trying to accommodate Vice Chair Burns' request that possibly a follow-up meeting, to the extent that we have access to age associated with the claims, that we could look at the 2022 data and see if we have any impacted claims in what we're looking at, so that we might vote related to that at a future meeting after we have that information.
And I have just a really quick follow-up question, because I think Dan raised something important, and I definitely don't want to gum up the works here. If we were to say, only look at the adult population for Skyrizi, does that limit the way the data is collected and reviewed for the other medications? So what I mean is, if we make those limitations on one medication, do we have to make those limitations on all medications that are reviewed?
I think I would want to seek advice of counsel on that, but my initial thought is that these drugs are not competing head to head against one another. These are drugs that are each unique to their own treatment and condition or class, whereas several of them are in the same class. So they're not competing for a spot on a list, if you will, and that they should each be looked at individually. And to that point, I believe our rules support that.
Okay, yeah, because I wouldn't want to, you know, upset the apple cart for everything.
So we can come back and at least see what is available from a data aspect, and if that triggers additional discussion or any individual board member asking for a motion, to amend this list, we certainly could do that if that works for folks.
I mean, I don't want to lose sight of what I believe I heard Courtney say related to Inflectra. So I know that we've been discussing Skyrizi up to this point, but I want to make sure before we move forward that the board does have some discussion about the information presented from staff related to Inflectra. So Dr. Burns?
Yeah, I would support removing Inflectra, just because it's odd to me that it's on there. And in the past, we have pulled out agents that had biosimilars or were a biosimilar. It's just odd to me that's on there. I would also just kind of like to point out that I know we're looking at 22 data, but Vyvanse is generic. And, you know, the cost is already decreased on the marketplace, and it's been generic, I don't know, for 6 months or so. So if that throws a wrench into it too, I apologize. But
Yeah, so again, the Vyvanse designation for that was just current, and the data that we're looking at for the concern is for 2022. That was our statutory requirement, is to look at the prior year. So the Vyvanse costs were from that time period. But it can be absolutely part of the discussion when we come to Vyvanse to understand that going forward, it's not going to be, it may not be as much of an impact, but there's no information at this point verifying that. So the board won't be able to do a vote today, but in order to update the timeline, my understanding is to go ahead and keep on the Skyrizi and provide the additional information associated more specifically around the age of treatments. And then is the board wanting to remove Inflectra because it was originally identified as having a biosimilar. It was just kind of an oversight during the drill down of the Excel spreadsheet at the time, back in November, December. So does the board want to look at removing that from the timeline?
I mean, Courtney, my thoughts are that we put both of those two items on our agenda for the next meeting to vote at the next meeting relative to both of the drugs that we've discussed. That would be what I would think would be perhaps helpful through the process. Does any board member feel differently?
No. Okay, we'll then set it up to have those voted on for next month to keep or remove.
Okay, that makes sense. And that would be on the May 15th meeting.
Yes. All right, well, thank you for that. I wanted to touch base real quick just about the updates that were done to the template. In itself, Melissa, are you able to throw up the template and just provide a quick oversight? Give her a second. Thank you. So again, I'm just indicating that these revisions were made last month. Melissa, if you can scroll down, really there were the majority of the updates to the template was arranging all of the heading sections to match the order of the statute and rule, and provided and in those sections, the ORS and the OIR was referenced underneath. In that little narrative, go ahead and stop right there, please, Melissa. As you can see, it starts with health equities, and then underneath the health equities, it identifies the ORS and the OERs, and then any data resources or resourcing or limitation, like where the data is coming from, or how we're utilizing the data, or if there's limitations in the scope and resources of that data. So this helps keep kind of in track and flow of our statutory requirements. There was no real significant changes, maybe some updates to some verbiage here and there, but everything else has still remained the same from the original template, short of just maybe the order and the additional information around the data sourcing. So I know that you have all reviewed it in the packet and the materials and stuff like that. So I just wanted to give the board an opportunity to provide staff with any comments or feedback, or if it looks good, then we will start putting the packets together for the first review starting next month. Yes, Dr. Burns.
I was gonna say I thought it looked great and I appreciate the uniformity. I didn't have any particular edits. And I thought you guys did a great job. Thank you.
Thank you. Dr. Harkin.
Yeah, so I think that wherever possible and practicable, you could report out the medians in addition or in place of the average for the cost. I think that that's maybe preferable. And I noticed there's some talk about the median and the mean here. That I think's been added, but there's still a lot of averages.
Yeah, for sure. Happy to look at with the possibility of that with some of the data that's already been collected and see if we can be rearranged to include the mean, median, and mode in some capacity. Again, some of that may be very drug specific depending on the information provided. Again, most of the reviews are for drugs themselves and the data we have for that drug specifically. So, but I appreciate that feedback and we'll try to implement that.
Okay.
Any other suggestions or feedback from the board members? Otherwise, I'm happy to turn it back to Chair Bailey. All right. Thank you. Chair Bailey, back to you.
Perfect. Well, thank you, Courtney, for providing us with the updated information and the kind of the consistent timeline or the consistent template that we'll be using moving forward. So I would now like to call on Ralph Maybrish and Courtney to discuss the generic drug report.
And thanks, Chair Bailey. I think Courtney's going to take this one.
I'm going to run with this one. So this is our third annual generic drug report that we're doing to submit. Melissa, can you please show the timeline? Thank you. So we've already started in on the timeline by getting it posted, the generic drug for review on April 10th, and we're going to discuss it briefly today. I do appreciate the additional comments that I've received from some of the board members already about perhaps looking at some additional information and adding a section around 340B. So hopefully we'll be able to implement those. I do have a request for all the board members. If you have any other insight, feedback, suggestions, to please have that posted to me by April 24th. So that I can finalize the reporting before having to send it over to have it designed, and for any other posting needs prior to May 8th. So the generic drug report itself will be posted with the material packet on May 8th with your approval by May 15th. And again, I'll probably be reaching out to most of you individually just to get some additional clarification and insight for the report itself. Once you approve it next month, again, I'll go through one last design review before having it posted to the website on May 27th and then over to the Oregon legislator by the end of the month in May. So any questions about the timeline before I jump over to the quick review of the generic drug reports? No. I do have to say thank you again. I really appreciated the conversations over the last week or so with each board member and your input and insight for this, and for the board members that are helping to provide additional information on some of the topics. So I'm actually going to still screen for a minute from Melissa and share so we can scroll through real quick. Hopefully everyone can see my screen. All right, starting in normal fashion, just a super highlight of the content. We're going to review the background, the authorized generic drugs, manufacturers, and the strategies that sometimes prevent or delay generic or biosimilar competition, generic and biosimilar related litigation and legislations that are occurring or have occurred, generic and biosimilar drug pricing, generics in other countries, formulary placement, drug shortages, biosimilar substitution, and with some wonderful recommendation from Chris for to include some information around 340B and its impact. So we'll add that also into the table of contents and additional information. Again, quickly, background is again just a highlight of what the generic drug report is and the statutory requirements that govern this report to be sent to the legislators. And then a quick overview of authorized generics and some additional information will be provided. Robert will help me with that in some capacities. Some of the information was also broke down under the manufacturer strategies to prevent delay. That includes the pay for the delay, a component around citizen petitions, product topping, limited supply agreements, before moving into the generic and biosimilar related legislation and litigations. So a lot of the information was researched and supported by some of the contractors trying to pull together substantial articles that kind of help support a lot of this information in industry. So if there's any additional resourcing the board members are able to find or provide, I can help implement that in. Otherwise, a lot of it was strongly researched and provided information to support this the content of the reports. Again, really briefly, we just kind of touched on what happens with generics in other countries. Due to kind of how the U.S. market is, generics are often more beneficial in the U.S. market versus other countries. And that's just because of how our health system structure is pulled up, along with where generic drugs fall on formulary placements under health coverage. Kind of addressing drug shortages and the impacts of what's happening with there, and a couple of recommendations that we found through various policies that were published. And then how generic and biosimilar substitutions can also help impact cost of drugs. And then the conclusion, I would like to extend an offer if any of the board members want to help kind of strengthen up the conclusion. Please send me any suggestions. I kind of left it at a high level at this point in case there was any additional information. Just wanted to provide that opportunity before strengthening it up. As I said, we'll be working with some of the board members over the next couple of weeks or next week or so to ensure that all information is provided before finalizing to go to get it sent to publish. So I know that's kind of high overview, but my understanding is everybody's already reviewed it, has already read it, and working with some of you individually on additional information. But I wanted to provide the board opportunity now at the meeting. If there's anything else within the board, within the generic drug report that you wanted to add or discuss. And hearing none, Chair Bailey, I'm happy to turn it back over to you.
All right, well, I appreciate it. And again, Courtney, I appreciate your hard work and the work of your team in helping to draft this document. So again, look forward to the continued feedback from the board, but I recognize that many members have already provided additional content and support related to it. So again, Courtney, thank you. So I guess I would now like to call on Ralph Magrish to lead our discussion related to Senate Bill 192, upper payment limit planning. Ralph?
Thank you, Chair Bailey, very much. All right, board. So before I provide an update on the progress the team and our contractor has made, we need to get a couple things out of the way by first explaining what an upper payment limit is. And second, candidly, to talk about the ever-growing larger and larger elephant in the room, which is all the swirl, misinformation, and fear-mongering that has begun around upper payment limits and candidly where it's coming from. So let's start with what an upper payment limit is. An upper payment limit is the maximum reimbursement amount above which purchasers throughout the state may not pay for a prescription drug or drug product. An upper payment limit creates a ceiling on what a payer can pay for a drug. It does not set the price a manufacturer can charge. And finally, rebates should no longer be necessary for high-priced drugs affected by upper payment limits, and you will hear me talk about that in more detail later. Now for the elephant in the room. Why are so many people out there opposed to something that is intended to help protect Oregonians and our healthcare system? Good question, right? Let's drill down on this for a few minutes. From our perspective, it starts with manufacturers, their trade associations, their proxies, and those who choose to support a doom and gloom perspective on upper payment limits for whatever reasons they believe and whatever their motivations are. Let's start with what Pharma purports as the 4 truths about government state price setting, most recently updated on October 10th on its website. First, they purport it risks patient access to medications. Pharma suggests PDABs are government price setting schemes that let politicians set medicine prices with little accountability to or input from patients and their doctors. They further suggest under the scheme, an unelected board of bureaucrats evaluates the price of medicines and determines whether medicines and treatments are worth paying for, with the state coming between patients and treatments and their doctors who prescribe them. So let's fact check this for a minute. Our Oregon board, are volunteers who care about the well-being of people in our state. You are not unelected bureaucrats. Secondly, you are not determining directly or indirectly whether certain medicines or treatments are worth paying for, even if you had upper payment limit authority. And thirdly, the board's efforts in no way, zilch, zero, nada, in any way whatsoever, put the state between patients and the treatments their doctors prescribe. Secondly, Pharma purports that PDABs and upper payment limits would reduce predictability for patients. They say too many unanswered questions remain. What happens if a drug becomes unobtainable at the board's arbitrarily set price? Or board decisions result in reduced treatment options for patients? Or what happens if middlemen reduce health insurance coverage for non-price controlled drugs that patients still need? And that's not all they purport. Politically appointed boards like these take control away from patients and their doctors, leaving access and affordability of life-saving medicines in the hands of each election cycle. So let's fact check this for a minute. These are all attempts at fear-mongering. If given authority to set upper payment limits by the Oregon legislature, the board will not set arbitrarily set prices. In fact, nothing the board does is arbitrary, nor do PDABs set any price at all. It sets an upper payment limit. Pharma knows their members set prices, not us, yet they continue to make these public-facing statements. Board decisions will not result in reduced treatment options for patients if manufacturers choose to leave the marketplace. It will be manufacturers who decide to reduce treatment options for patients. This is a false choice based on a false narrative. Thirdly, Pharma purports that PDABs and upper payment limits ignore the true reason for high patient out-of-pocket cost. They purport these boards fail to address the root problems facing patients. They purport that as abusive practices of pharmacy benefit managers, suggesting that too often insurers and PBMs use harmful tactics like copay accumulator adjustments or copay maximizer programs to deny patient benefits of patient assistance programs. They suggest utilization management tools like requiring prior authorization or failing first on other therapies, which can create significant barriers between patients and the medicines they prescribe. They suggest PBMs choose to pocket tens of billions of dollars in rebates and discounts they receive on medicines for their own profit instead of sharing these savings with patients. So let's talk about these, right? Pharma asserts the root problems facing patients are abusive practices by PBMs, which, someone correct me if I'm wrong, but all starts with rebates. Who pays rebates? Who created the whole gross to net construct of having a rebate model? Let's have a conversation about how rebates that manufacturers start out with to buy and create market share are the great creator of these artificially created problems. Let's have a conversation about what kinds of inequities those rebates create in terms of access, because from an economic, academic, or practical business perspective, rebates exist in order to charge a different price to different customers for the very same product. Would patient assistance programs even be necessary if the real cost was even known? Would small rural oncology clinics have to pay for more for drugs through insurance companies if they didn't use the carrier's specialty pharmacy? If the whole model wasn't dependent on, wait for it, manufacturer rebates. Fourthly, pharma purports. It jeopardizes the development of new medicines. They suggest that we've already seen the impact of price setting policies at the federal level and that PDABs could have the same effect. They suggest that government price setting policies reduce biopharmaceutical companies' abilities to invest in post-approval research required to see if they can be used in new ways, especially in disease areas like cancer. They suggest that analysis shows that investments in research and development are already shifting away from small molecules because of the Inflation Reduction Act's pill penalty, despite the benefits of these medicines for patients. Let's talk about this for a few minutes. The quote, impact ability to invest in post-approval research to see if drugs can be used in new ways. Is that the same thing as seeing if a drug can continue to get new patents after their original one was approved? They purport analysis shows that investments are shifting away from small molecule drugs. The source that they use in that study, the analysis provided by Global Data's Pharma Intelligence Center, in the very same article and study that they link to, says, despite the negative impact of the IRA on small molecule companies and the rising capital cost that nearly affects every stage of development in the biotech industry, that impacting both biotechs and investors, the biopharma industry has witnessed a surge in increased collaborations. Now, I am not an MBA, but doesn't a surge in increased collaborations mean a surge in acquisitions and mergers to buy up competition? Let's shift away from the pharma piece for a moment. Let's talk about the version 7 of a newly released 2024 Johnson & Johnson 16-page report that it's been floating around the country through various iterations and groups titled The Influence of PDABs and Upper Payment Limits on the State Drug Pricing Ecosystem, a paper that, I quote, aims to address potential intended and unintended consequences of PDABs and upper payment limit implementations on branded medications for states and the broader healthcare system. This report was in fact recently shared with us by a local 340B covered entity. So board members, I tell you, have no doubt that these are the kinds of things that are floating around in our communities. I'll spare you much of the gory details of this beautifully formatted report, but trust me, it's the same message, just in greater detail. It literally is Chicken Little, the sky is falling. It's the fairy tale trying to create a hysterical or mistaken belief that disaster is imminent should upper payment limits occur. And wait for it, the real irony here, folks, this is Johnson & Johnson, right? The great tagline most associated with this company for decades that's actually trademarked for its baby shampoo. Wait for it, no more tears. Yet they're literally trying to create tears of fear and anxiety for people about a state program that is designed to help them from these very things. So let's get into this just a little bit more. What does J&J say? They say upper payment limits do not address cost and price in the supply chain. What do I say? The upper payment limit applies to the supply chain. The supply chain is the whole drug distribution system. When the drug is bought, where it's bought and sold, and changes ownership. That means wholesalers, repackagers, medical and healthcare facilities, pharmacies, medical practices, and clinics, among others. An upper payment limit would apply to insurers and their vendor PBMs, which are not part of the supply chain. What does Johnson & Johnson say? Upper payment limits will not reduce consumer cost. Well, what do I say? The upper payment limit applies to consumers at the point of service. Under a pharmacy benefit, the UPL applies in the deductible and when coinsurance applies as well. Coinsurance applies to many high-cost drugs, and similarly, the same challenges and issues exist in medical claims. And to that point, this is not a true statement. What J&J says, upper payment limits do not address the value of a product. Well, J&J is correct in that. The upper payment limit addresses affordability, Medical professionals, patients, and health plans determine the product value. A high-value product is more likely than a low-value product to create affordability challenges. Highly valuable items and services are not typically affordable when an item or service is priced to reflect the value of a product. The notion of paying based on the product value is unique to pharmaceuticals in the United States healthcare system. And in fact, that construct and notion will not make the US healthcare system any more affordable. Johnson & Johnson says in this report, upper payment limits do not account for manufacturer rebates that lower the net cost of prescription drugs. Well, what does Ralph say there? A board would most certainly consider manufacturer rebates if a manufacturer willing to provide it, or a health plan was permitted to share that information to inform the board of per unit rebates. Knowing the average rebate in a state would allow the board to convert that average rebate amount into an upper payment limit. This would benefit patients directly at the point of service, which would also address the persistent and consistent industry complaint that their rebates do not benefit payments. An upper payment limit could account for many aspects of market operation if the industry An upper payment limit could account for many aspects of market operation that the industry dislikes if manufacturers would provide the data to boards and problem solve with boards to address the overall dysfunction instead of criticizing our work from the sidelines. Finally, Johnson & Johnson suggests that upper payment limits do not account for the cost of research and development. Again, stymieing innovation. What's the response there? The U.S. pharmaceutical industry is the most profitable industry in the United States, if not the world. There is plenty of money for R&D despite making drugs affordable. In fact, speculation is that the industry spends more on advertising and executive compensation, which, by the way, includes stock buybacks, than it does on R&D in totality. So the cost of R&D is also declining. That's attenuated by new clinical trials, faster FDA approval, and significantly higher probability of approval than ever before in past rebates. So all of this indicates, I repeat, all of this indicates that there is considerable room for reduction in consumer and health system cost without impacting or harming research and development. So what is all of this? It's a bunch of malarkey, and I am calling it out today, right here, right now, to you, our board, and to the people of Oregon. In case anyone doesn't know what the meaning of the word malarkey is, Collins Dictionary defines it as insincere, meaningless, or deliberately misleading talk and nonsense. To the board, I remind you that our statutory charge is to protect Oregonians from the high cost of prescription drugs. And part of that responsibility is to simply call out insincere, meaningless, and deliberately misleading talk and nonsense when we see it. That is, in fact, what we are doing right now. So to those who have chosen to stand with manufacturers in this issue, in their public relations departments, their marketing strategists, and sing these songs of fear and tears and doom and gloom, we invite you to join us in singing from our sheet of music about hope and meaningful changes, including how drug rebates from manufacturers are, in fact, the root cause of prescription drug distortion prices in the marketplace. To that point, because branded manufacturers in this segment, the market, have made it so complex and so opaque for so many years, the industry itself has been able to capitalize on the lack of knowledge about its business processes. Hello, rebates. The industry has used the complexities of this business model to continue the same songs of fears. So we hear statements and veiled threats from manufacturers in other states with upper payment limits that they'll just have to pull out of the state entirely. We can't continue to make money here, they say. Well, let's unpack that a little bit. That's a false choice when a manufacturer could still sell the same drug for 20 or 30 or 40% more than that upper payment limit in Europe or Asia. So it's a great message to send to investors and the public. Patience, if that doesn't tell you where a company's priorities are, to put investors and profits over patients' lives, I don't know what does. Simply put, If Oregon is ever to get upper payment limit authority and a manufacturer were to take such actions, I believe it would be appropriate for this board to have conversations and consider a recommendation to our state legislature to pass a bill to simply divest the state of its investments through PERS accounts and the state treasury, to remove our support for such companies. Why would the state want to support a company that takes such a position that clearly puts their profits over the well-being of Oregon? So industry voices have said, and their proxies have also said, it's not us, it's the PBMs and the insurance companies. Well, they're not entirely wrong about that. Let's take a step back for a minute and contemplate that drug makers need drug dealers and drug dealers need drug makers. It's a symbiotic relationship that's mutually beneficial to everyone except the end user, the consumer. And before the PBM folks get too spun up and start contemplating suing for calling them drug dealers, they do, in fact, as a practical matter, make deals for prescription drugs. So to industry's point that many PBMs are in fact owned by insurance companies, we know that insurance companies also engage in processes where for some drugs, those hefty drug rebates originated by manufacturers that then flow through PBMs do not find their way back to individual patients who may have high out-of-pocket cost, while the insurer uses those rebates to cross-subsidize healthcare costs for their covered lives, or in fact return some of it back to the plan sponsor to lower their cost. We know this. So where do all these inequities of cost and access start? Not with PBMs, not with the insurers. They undeniably and factually start with manufacturers who, by design and intention, distort the marketplace with rebates. So let's talk for a few minutes about what upper payment limits should do to promote consumer ability for drugs that have them. Upper payment limits should strive to first improve patient access to drugs. Pharmacy drop rates should go down. That's when someone actually doesn't pick up a prescription drug at the pharmacy counter. That because they can't afford it, patient adherence should go up, and utilization management or prior authorization should be for clinical purposes only and no longer about cost containment. This should be music to patient advocates' ears. It should improve manufacturer product access in the state market because cost-based utilization tools should be minimized. Greater adherence for those already on treatments because they could afford them, and more sales to those who have not had that drug previously. So this should be music to manufacturers' ears. Upper payment limit should reduce health plan cost for products. Plan reimbursement of products to pharmacies and providers would be reduced commensurate to lower drug costs for providers and pharmacies. This should be music to plans' ears, providers' ears, and pharmacies' ears. And finally, upper payment limit should reduce overall market distortion. So to the extent that PBMs and large institutional providers distort the market and drive up consumer health plan and manufacturer costs, an upper payment limit when level set for the market for those individual drugs. So market competition would continue, but it would be reset at an upper payment limit as a starting point. And even if some competitive opacity remains in the marketplace after an upper payment limit is created, the consumer is protected since the upper payment limit is a public number and is the basis for all consumer costs. This should be music to everyone's ears. So pause for a moment, because I can tell you that when I started preparing for this segment of the discussion, it was not my intention to have this rabbit hole discussion and conversation with you about this today, but this was supposed to be a briefing and we're going to have time for that. But this was necessary first to frame the conversation based on the environment that we're working in, and secondly, to get the elephant out of the room. So in this very moment, we're going to open the virtual door to this virtual room, and we're going to get this very real elephant out of the room. So elephant, bye-bye. It's out there. Now we can get down to business. Melissa, if you would be so kind to advance the slides. Thank you so much. So as a reminder to folks of what Senate Bill 192, Section 3 does, It directs us, the board, to develop a plan to establish a methodology for upper payment limits, an analysis of what resources are going to be needed, how it will be enforced, the impact on state payers being PEB, OEB, and other state administered benefits, and health plans and other programs around the state. Melissa, next slide, please. And no later than September, as folks are aware, we are going to submit a report to the legislature to do so, and it will discuss an impact analysis of potential cost and savings with relation to the state, insurers, hospitals, pharmacies, and consumers. If you would, Melissa, next slide. Thank you. So, as folks know, we've contracted with Myers and Stofert to help us through this with the engagement, and we have set up constituent groups, and the goals to do that are to understand their concerns, hear their questions, find out what their support or opposition to upper payment limits are. And if you would, Melissa, next slide. Thank you. So next piece of this is to identify those groups, and we have done so through much of our stakeholder work and engagement already. To that point, we have a survey instrument that will be going out very soon to these constituent groups. We've done outreach with our State Pharmacy Association, with folks from the National Association of Chain Drugstores, with the Oregon Primary Care Association, with the Cascade AIDS Project, with the AIDS Drug Assistance Program, at Care Assist at the Oregon Health Authority. We'll be meeting with the Oregon Hospital Association later this week. And we will be hosting, as mentioned earlier, we've hosted a number of consumer groups already around the state, and the 2 upcoming and our virtual meetings. To that point, those virtual consistent focus groups that will start next month will also be held in with both Spanish and ASL interpretation services available. And Melissa, if you would, go to the next slide. Thank you. So to talk a little bit about the approach for that we're taking for this engagement of a pre-meeting constituent survey approach, I'll speak to this. The board itself and our work as staff in supporting you are going to be providing a skeletal framework or straw model of an upper payment limit structure to elicit responses for both broad and specific issues that individual constituent groups may identify. The framework that we are taking for this is built around a strengths, weaknesses, opportunities, and threats, or SWOT analysis. And the topical areas that will be included in those will be impact on an organization's drug spending and budgetary considerations, their ability to afford to purchase medications currently and the sustainability of that, and the potential administrative burdens or operational challenges around implementing upper payment limits. And if you would, Melissa, next slide, please. Thank you. So these focus groups will begin in May. They are designed to facilitate meaningful dialogue and solicit clarification or information post-survey. We have some of the sample questions, I think, in front of you as to what that would look like, and soliciting from these constituent groups, what would an ideal program look like? What are the barriers and challenges that you have, and what are your concerns? And then finally, Melissa, if you would, the next slide. Thank you so much. So our community forums have been very well received and appreciated in the communities that we have conducted them in. We look forward to this work and continuing to hear from Oregonians. Couple last things as I open up to the board for question as time permits. You have this information in front of you. We call upon you and the general public to participate in these to the extent that you're able and possible, and happy to take questions or engage in discussion or next step conversations with board members. And thank you again for letting me level set with you the landscape that we are working in and conducting this study and analysis. Happy to take your questions. Robert.
Hey, Ralph, I'll keep my comments to kind of the update that you provided on the work for implementing or understanding what the upper payment limits could be and how it would be implemented. You mentioned that a survey was being constructed to go out to a bunch of different stakeholders, and that it would be released this month. How do you identify what that list of stakeholders is, or is that a publicly available document?
Sure, I believe we certainly can make that publicly available. I'm happy to run through what the groups have been, and someone can check me on this if my team, I'll invite you if I'm missing anyone, but in sequential order of hospitals, we have obtained a list of hospital CFO folks through the Oregon Health Authority and their hospital cost reporting program, and using that as our distribution with those folks. And we have, as mentioned, we'll be meeting on Friday with the government relations folks from the State Hospital Association. On the carrier side, we will be utilizing the network of carriers that participate in insurance carrier calls through the Department of Consumer and Business Services, through our regulated health insurance carriers and our contacts there, of which we have already given those folks a courtesy heads up. For state pharmacies themselves, we have collaborated very closely with the Oregon Pharmacy Association, the State Pharmacy Association, and their executive director to provide us with a list of independent and small chain pharmacies to communicate with directly, and in fact have had conversations with the National Association of Chain Drugstores, and we'll be meeting again with them later this week to identify a localized or regional cohort of their chain folks that will be able to participate. And on the 340B front, we've worked very closely with the Oregon Primary Care Association and obtained a list of their CEOs that will be distributing this survey to, amongst other 340B covered entities. As mentioned, the Cascade AIDS Project, the AIDS Drug Assistance Program at OHA, and we are exploring a couple other folks as well through the 340B chain as well. And then of course, consumer facing the community forums that we've held around the state. Team, if I have omitted or spaced on anyone, I invite you to jump in, but Robert, I think that's pretty much the universe.
It is a universe, so that's great, and I applaud you for that effort. You know, getting stakeholder input, I think, is critical to this process. Is the survey, I know it's been developed by by staff. Is it something that board will see, or is it?
So we certainly can, and thank you for flagging this. And some of this, as you can understand, has been managing the competing time, interest, and constraints that we've been working through. But certainly can share those survey instruments with board members directly. To that point, of course, these are also instruments that will be included as attachments or appendices in a final draft report that will come to you all as well. So again, new standing agenda item going forward throughout the summer, and updates and engagement to the extent that we can engage or have board members participate in this process, but we'll welcome you to do so.
Great. Thank you. Thank you, Ralph.
Thank you. And other board members.
Ralph, I guess I'll just follow up. Not quite sure how to do so, but follow up on the sentiments you expressed to reference that we really do encourage people to participate in these listening sessions. So I've personally attended 2 of the 3. Vice Chair that's happened so far. Vice Chair Burns is participating in some, and I'll be participating in others. But these have not been as well attended as I might have liked to have seen. And I just want to make sure to reinforce that we are providing these opportunities to hear from the community. And I really encourage individuals, to the extent that they're able to participate in these. It is frustrating that I hear a lot of the less than direct communication related to what is going on related to Oregon PDAB or other PDABs, where we have provided opportunities for this direct and transparent communication. So as the board chair, I do want to encourage those listening today and those interested in the process in general to participate in the direct and transparent communication channels that we have set up. Furthermore, following up on, again, what Ralph presented, I do want to reinforce that I personally, and I believe all the board members do review all of the written comments, and I do, as well as the verbal comments, and I do want to make sure that we are reminded of what our statutory authority is in Oregon versus other PDABs throughout the nation. I see sometimes the message and the indirect communication that's happening broader is not necessarily specific related to the statutory authority that we have in Oregon. So moving forward, it would be very helpful if that's kept in consideration of what we are able to do right now with our statutory authority here in Oregon. Does anyone else have additional follow-up discussion that they would like to provide before we share information about announcements as well as open up for general public comment?
If I may, Chair Bailey, I'm encouraged to hear the conversations that are coming out and the ideas that are being presented. As a community pharmacist, you know, we hear these things and we're at the bottom of the food chain. And so it's the patients and us standing at the counter trying to figure out why this drug costs so much, why this drug can't be dispensed to them, why the PA is taking so long, why they still need to try other treatment modalities. You know, the questions go on and on and on. And the effect to the patient is usually not very good and ends with a very high price tag in most cases. So I'm anxious to hear more about the information of the UPLs, the good, the bad, the ugly. So I reserve judgment a little bit because I worry about some of the stakeholders that might be in the drug delivery chain, as a pharmacist, for example. But I'm excited to go through this and hear and maybe dispel some of the things that are being said out there against them. So I welcome the stakeholders to participate. I hope they do. Thank you.
Thank you, Mr. Murray. All right, well, if we don't have further comment or enhanced discussion related to this topic at hand, I would like to announce that our next PDAB meeting will be on May 15th, 2024 at 9:30 a.m. And I would like to then transition to asking staff if there's any additional announcements.
Thank you, Chair Bailey. None at this time, other than again, thank you to folks that have participated previously in our community forums, and look forward to people joining us in either Bend or Medford later this month or online in May. Thank you so much.
Perfect. Thank you, Ralph. So moving on, this next portion of the agenda is for general public comment, for comments that were submitted in advance. The board received 6 general written comments, which are posted on the website. Written comments are reviewed by the board prior to the meetings, but the board did receive today 3 requests to provide oral testimony. So in order of what's presented here today, we have Mr. Nathaniel Brown from the Chronic Disease Coalition related to the April 17th hearing. I would like to remind, before Mr. Brown starts his testimony, that individuals, if you could please state your name and the organization before you begin. Also, you do have 3 minutes to speak. The board will not deliberate on issues or requests during this general public session. So Mr. Nathaniel Brown, if you are in attendance and interested in presenting, please, you have the floor.
Chair Bailey, excuse me, this is Melissa. The 3 speakers are below on page 3.
Oh,
And they
yes.
began with
Melissa, I appreciate your correction. I guess I will. So just to redact what I presented earlier, I do want to reference the 6 companies that provided written comment. It is again posted on our website, but I am going to read it here, and then we will move forward with the 3 speakers. So my sincere apologies for that error, Melissa. Thank you for making the correction. So the companies that did provide written comment that you can see on the board website is Mr. Nathaniel Brown with the Chronic Disease Coalition related to the April 17th hearing, Kathy Suter-Giles related to Prolia, North Sanders from SAFE related to vaccines, Jay Peterson, Tiffany Westrich Robertson related from the Internal Foundation of Autoimmune and Autoinflammatory Arthritis related to, I think, all medications we discussed, and Daria McGrew related to the April 17th meeting. So again, this is my correction. Those were the stakeholders who provided written public comment. Related to the speakers, again, I'll reinforce if individuals could please state their name and organization that they're referencing or representing, as well as to reinforce that each speaker has 3 minutes. So the first speaker that signed up for testimony is Tiffany Westrich Robertson from the International Foundation for Autoimmune and Autoinflammatory Arthritis. Ms. Westrich Robinson, you have the floor.
And Chair Bailey, this is Melissa again. I've searched and cannot find Tiffany in the meeting unless Tiffany's in the meeting under a different name or a phone number or another.
Okay.
So
Well, then I think we will do is we'll move to the next presenter. And if this individual is able to maybe utilize our chat function to identify that they might be here, or perhaps they can contact Melissa directly at 971-374-3734. We can move Tiffany Westrich Robinson's comments to the end of this session. So if you're here, Tiffany, please utilize those resources to make it known that you're here today. So then moving to the second speaker that wanted to provide oral testimony, we have Ms. Tanya Sorrell-Neal from PCMA related to UPL. Ms. Sorrell-Neal, if you are in attendance today, you do have the floor for 3 minutes.
Thank you, Chairwoman Bailey and Director Magrish. As you all are in the early stages of this UPL conversation, I'm going to pass on making any comments at this point and give you back 2 minutes and 35 seconds.
All right, well, thank you for being here today. So the next speaker that we have listed to present today is Daria McGrew from Pharma. Daria, if you're here and if you would like to provide testimony, you do have 3 minutes and the floor is yours.
Good morning, Chair and members, confirming you can hear me. Chair Bailey and members, thank you. Daria McGrew on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. First, just want to appreciate the staff's work and revision of your draft template to reflect the entirety of the board's mandate. We do have a few comments and questions about the revised template. We would request and suggest more clarity around your term PBM concession. We're not clear what that means with respect to the way that the supply chain works, and there are conflicting descriptions in your rules and your template. Manufacturers pay rebates directly to PBMs, which then pass them on in whole or in part to health plans or employers according to the terms of the client's agreement with the PBM. So urge clarification there. I refer you to our letter for additional comments and more detailed responses to the revised template. Regarding the generic report draft, we'd like to note significant misinformation and claims about the practices of branded drug manufacturers in a report that is supposedly focused on generic drugs. Given the extremely short timeline of public comments, we were not able to include rebuttals in this letter, but we do plan to respond with more information to the draft prior to your next meeting. Finally, a lot was said here today. We have offered and continue to offer to provide more detail on our viewpoint in this debate, should we be given the opportunity to speak for more than 3 minutes at a future meeting. We could address the board. Thank you.
Ms. McGrew, thank you for your comment. I do want to circle back and see if Ms. Tiffany Westrich Robinson is in attendance and would like to provide oral public comment. Melissa, is it fair for me to assume that you have not received any communication related to the speaker?
I have not received communication and I've searched and Tiffany is still not in the meeting.
Okay, well, I appreciate that. Then with there being no further business before the board, we do need a motion and a second to adjourn the meeting. All in favor, please say yes.
Aye.
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 And any opposed, please say nay. All right, well then, with that, this meeting is adjourned. Again, I do want to reinforce for everyone to please mark your calendars to join us for our next meeting, which is on Wednesday, May 15th at 9:30 a.m.
Thank you.
Thank you.
Thank you.
Thanks, everyone.